As you know, the first human genome, it cost $3 billion and it took 10 years to sequence. Now, due to the significant advances in genomics, we can do whole genome sequencing for less than $500, and we do it in less than a week.
Welcome to the third episode of the MGI Tech podcast. Today, we're dialing into Doha to chat with Professor Medhat Askar, Associate President for Clinical Affairs and Professor of Immunology at Qatar University's College of Medicine. We'll be talking about his work in Transplant Immunology, discussing how the evolution of next-generation sequencing technologies has helped overcome challenges in histocompatibility, and learning about how genetic identity testing can help achieve successful transplants. I hope you enjoy the episode. If you do, remember to follow and leave a review on your favourite podcast platform. Okay, good morning, Professor Askar. Thank you for joining us today. To start off with, could you just give us a quick introduction to yourself and your work?
Good morning, Will. It's a pleasure to be with you today. I am Medhat Askar. I'm a professor of immunology at the College of Medicine in Qatar University. I'm also the Associate Vice President for Clinical Affairs in Qatar University, overseeing clinical training, clinical education, clinical research, clinical trials, clinical appointments in the university, and continuous professional development. So everything clinical at Qatar University. I'm also the division head of clinical immunology and transplant immunology at Hamad Medical Corporation in Doha, Qatar.
Perfect. So speaking of your research, could you talk about a little bit more detail about your work and how you address the challenges of histocompatibility and immunogenetics when it comes to organ and bone marrow transplantation?
So I'm both a researcher and clinical practitioner. I'm a physician by training, specialized in lab medicine, particularly the field of transplantation and immunogenetics. One of the biggest challenges in transplantation is the immune recognition. And because when our immune system recognizes the transplanted organ or tissue or bone marrow, it mounts immune response against that. And that leads to ultimately rejection and failure of the transplant, which is not a good thing. So we try as much as possible to match donors and recipients. One of the most influential systems in this matching process is the HLA, or human leukocyte antigen. This particular protein is encoded by the major histocompatibility complex on chromosome number 6. And it is by far, with a huge margin, the most polymorphic part of the human genome. And historically, because of how expensive it was to sequence, we didn't even rely on sequencing technology. We relied on less informative methods, such as that interrogate targeted sequences in the HLA region. And particularly a part, we call it the peptide binding domain. And this peptide binding domain part is a small part of the sequence, but it is the most polymorphic and the most known to be clinically relevant, just because of lack of high throughput, affordable sequencing method. As you know, the first human genome, it cost $3 billion and it took 10 years to sequence. Now, due to the significant advances in genomics, we can do whole genome sequencing for less than $500, and we do it in less than a week. So that's why so having this ability and the access to high throughput, affordable sequencing technology allowed us not only to sequence the most critical part of the antigen peptide the peptide binding part of the molecule, but the entire whole gene. And that's what we use now for the basis of matching donors and recipients, mainly in bone marrow, but more and more we are realizing the advantage of doing this for solid organs as well.
Yeah, that's fantastic. It's definitely a sort of paradigm shift in the technology that's available. When would you say this this technology has got good enough, to be used, clinically? Obviously, it's still fairly early stages, but how long has it been around where it's been able to make this impact?
That's a great question. And this technology, of course, has been in research, for more than 2 decades now, but it really didn't reach a state to be utilized clinically until probably 10 years ago. And I remember in 2000, particularly in the field of transplantation, our laboratory was one of the first 10 labs around the world. And by our laboratory, I mean, back in the time I was in the United States, in Baylor University Medical Center. And our lab was one of the first 10 labs in the United States and in the world to implement sequencing, next generation sequencing in clinical transplantation. And at that time, we did whole gene sequencing for all our bone marrow and transplant patients and donors. At that time, the idea was, radical, if you may, because most people didn't think that high resolution even is needed that much for this application, particularly in solid organ. But actually, we did it because the access to high throughput sequencing technology made it less expensive to get high resolution typing than using traditional methods to get low resolution typing. And that's actually how we convinced the administration. We said, put science aside, just talking economics. It makes more financial sense to do a high throughput sequencing for all our patients and donors. Of course, as a side product of this came the clinical utility and the advances that allowed us to recognize even a role for sequences that we didn't use to sequence. We had no access to this information before, and it turned out to affect not just the structure of the protein encoded by coding sequences, but also non-coding sequences appeared to affect the level of expression, which increases the level of immune recognition, which affects outcomes. So it's really, it provides more tools, if you may, to support the clinical decision making.
Yeah, that was going to be my next question. From the broader sort of high resolution sequencing, in addition to the kind of core indicators that the traditional indicators for whether there's a match, what are some of the other main sort of markers that you can look at now? And are there any that you knew about before but are now more available? And then examples like that. Are there any others where you hadn't even looked at it and weren't aware that it could be a factor? The fact non-coding sequences have an impact is quite interesting.
That's really a very, very important point. As I said, historically, we used to look at not even the whole coding sequences, just small part of it, particularly exon 2 and 3 in HLA class 1 and the exon 2 in HLA class 2. That's everything we based our matching on. Now, not only we can do all coding regions, all exons, but we do whole gene. Oftentimes, we look and we identify points that leads to not necessarily change in the structure, but either change in level of expression or change of antigen presentation or something else that affects outcomes. So there is a SNP in the 3' untranslated region in the HLA-C region, HLA-C locus. There is another one in the same region, but but different SNP in the HLA-DPP1 locus that also affects level of expression. It You have one allele, it is low expression. You have the other allele, it is high expression. And that affects it. You really don't need to be appreciative immunologist to suspect that if you have higher expression, you have higher exposure to the immune system, you have worse outcomes. So it's as simple as that. Also, there are interesting parts that we wouldn't even have the tools for before. Like there are parts of the protein, so they are coding sequences that encode like exon 1. It encodes in the B locus, it encodes the B leader sequence that is not part of the mature protein because it gets deleted. It is called leader sequence. Once it leads the HLA-B molecule through the intracellular pathways to reach it to be expressed on the surface, it gets chopped off and it is not even part of the protein anymore. Yet we found that some SNPs in this region affects outcomes. So the more we look, it gives us tremendous access to information because, as you know, the coding sequences in the MHC or otherwise is only 2% of the human genome. So it's naive to imagine that this 98% of the genome just sitting there not doing anything. And without access to affordable and high throughput technology, sequencing technology, we didn't even begin to investigate what these massive amounts of sequences are doing.
Yeah, that's fascinating. So what kind of impact clinically does this newer approach have on actual success rates? Do you see like an impact in transplant success from having so much more information up front about the match?
Okay, I'll be honest with you. I don't want to oversell the product. This technology has not been in access in a large number of labs. So there, as I said, the first tier of early adopters started this about 10 years ago. But I would say that it didn't become widely accessible until probably 5 years ago. And even that's mainly in the Western world and probably high resource countries like China and other places that have access to this technology. But there are massive parts of the world that is still, probably will have access to this later. And I imagine as the cost keeps declining, which is happening really in a very impressive way, more and more of the transplant programs have access to this. So that's one point. So we are talking about this technology becoming available to wide representation of transplant programs in the last 5 years. Once we identify these sequences, it is not like we're going to see the outcome right away. We need to do the studies because there are massive, regions of the gene that needs to be sequences. And every time we look, there are so many polymorphisms that could affect outcomes. So it's not like every polymorphism is affecting outcome in particular clinical context. It may be affecting outcome in rheumatoid arthritis, in immune deficiency, and some are affecting in bone marrow transplantation. So for this, we need clinical trials. And also when it comes to outcomes, we really need to be very careful because you could have the best matching in the world, but there are variations in the disease state, in the preparative regimen, in the GVHD prophylaxis, in the patient demographics. So outcome and matching, they are just, there is so much that happens in between. So it's very hard to make direct link that you have better matching. Every little bit helps, as one of my mentors used to tell me. But so it will take a while to show these, to identify these targets, implement them in clinical algorithms, and start to see the outcomes. But Without access to this technology, this whole cycle wouldn't even begin. So we are on a path, and it just takes as long as it takes, but we have to start somewhere.
Yeah, absolutely. So yeah, that brings us on nicely to something else I was going to ask about. Another part of the process, which is post-transplant monitoring patients and how the sort of graft is being accepted. What markers and techniques can you use to monitor that process and see how things are going and help the patient if there's any problems?
There are two categories that this applies to: the solid organ transplantation. Ultimately, all solid organ transplants are lost to rejection. So we need to monitor this, and you reject the heart or you reject the kidney, you go back to dialysis, but you reject the heart or a lung, then unless we get you urgent, a retransplant, the patient dies, because we cannot live without these guys. So for those, we really need very close monitoring to make sure that these organs do not get rejected. The gold standard has always been biopsy. But as you can imagine, it's expensive, it's invasive, it's you cannot do it often because you don't want to eat up your organ by biopsying it one bite at a time. You need to leave some part behind to do the job. So that's why the concept that was born in cancer related to liquid biopsy became applicable to solid organ transplant, so that you don't keep chopping away from the graft. You hopefully it is at a lower cost, and hopefully it doesn't subject the patient to the potential complications of tissue biopsy. And one example we have using the sequencing technology that we wouldn't even dream of if we didn't have access to this high throughput sequencing technology is donor-derived cell-free DNA. So cell-free DNA is a part, shedding cell-free DNA is a part of the normal wear and tear process. So it's normal. If I collect a blood sample from you, I'm going to find cell-free DNA, but it's going to be derived from you. So if I collect a sample from a transplant patient, I will find cell-free DNA. If he is not rejecting, that is going to be 100% his own. Because even if the kidney or heart that is 150 gram or so is shedding cell-free DNA, there is no way it will be detectable in the ocean of cell-free DNA being shed from 100 kilogram recipient, right? It's a proportion. But when the organ starts to reject and the cell death far exceeds the normal rate of wear and tear, then you start to detect the donor-derived cell-free DNA. And for cell-free DNA to be able to do this, you need to have very accurate technology that distinguishes donor from recipient. It's like crime scene investigation that they do to identify the individual. So we need to identify the recipient and we need to identify the donor. And historically, there were primitive methods for using this that had like STR, short tandem repeats, that had a sensitivity limit of 2 to 5%. With next generation sequencing, we are talking about sensitivity limit of 0.1%. And we are talking about accuracy with very small CV. So that really allows us to identify very accurately which proportion of the cell-free DNA is derived from the donor and which one is derived from the recipient. Just to give you, I gave you a sense of the difference in sensitivity, just to give you a sense of the level of distinction between donor and the recipient. Historically, STR used to have 14 markers in most commercial kits. when we are talking about cell-free DNA using next-generation sequencing, we are talking about 300 to 13,000 SNPs. So this is what high throughput next-generation sequencing means.
Yeah, that's fascinating. So that must make a huge impact on, as you say, how often and how closely you can monitor that process.
Absolutely. In our lab, we do it with every HLA antibody testing. Anytime there is any shadow of suspicion of rejection, we perform cell-free DNA because it is not prohibitively expensive and it is as less invasive as it gets because it's just a sample of peripheral blood.
Yeah, that's great. One other thing I thought of before that I don't know whether this is maybe another clinical implication when you're looking for a donor. Are you able to perhaps screen more donors because it's because the technologies are readily available, less expensive, all the rest of it. Whereas before, maybe you would have to select some very high likelihood relatives and and just test those. Could you now potentially screen more potential donors and find a match that might end up being better, or have more backups, have more options?
Absolutely. So that plays more in the bone marrow transplant world. And so organ transplant, there is global organ shortage. So we really don't have this luxury of picking and choose. We'll just take whatever we have. Even at times, we know that this is a high risk for rejection. But would you let your patient die of heart failure tonight? Or give him a fighting chance and give him a heart transplant that is high immunologic risk, but we're going to monitor them. We're going to make sure that we're going to augment their immunosuppression. Maybe they survive a couple of years. And maybe by then, the science have advanced and we came up with a solution it's just we figured it out one day at a time for these patients who are really, really critically ill. And for them, transplantation is the only hope of life-saving chance. But in bone marrow, historically, that actually for registry, bone marrow transplant registries, for the cost of typing 1,000 volunteers, now they can do 10,000 or maybe 30,000 volunteers, which translates into a higher availability and higher access to this bone marrow life-saving transplant. And also, it allows them not only to sequence, as I mentioned, the small part of the genome or limited number of loci, but having whole sequencing for all loci. What this really leads to is it expedites access to already known donors to be a match versus having partially typed donors and we have to type them one at a time. Now, we already, before we even do any further typing, I have the patient typing and I have millions. I think now there are like 40 million donors on the world registries.
Yeah, that's great. So again, it's another sort of paradigm shift in what's available in that sense. And I guess even for the solid organ transplants where you can't really pick and choose donors, as you say, does the kind of deeper understanding, the more comprehensive understanding you have of the match or not, does that give you more information about what's going to be needed post-surgery?
So there are algorithms that help to, as I said, we're not going to pick and choose, but we can immunologically risk stratify. So when we have better appreciation of the level of matching, not that we're going to turn down the less immunologically matched, but we can identify them more precisely and we can give them more augmented immunosuppression or monitor them more closely, just manage them differently. I think in any day, I would take knowing something versus not knowing it. So no matter how the limitations are and what you can do with the information, definitely not having the information doesn't help. And I give you a small example, is that some of the HLA antibodies are allele specific. So historically, when we typed the patients and donors on the antigen level, and the patient is having what seems to be antibodies against their own antigen, but actually they are not. They are against the different allele of the same antigen group they have. So this way, when we are matching them with a donor, the donor may seem to be antigen match, but at the allelic level, they are allele mismatch, and for which the patient is having high level of donor-specific antibody. So knowing these, all of these intricacies wouldn't have even been possible without access to high throughput sequencing technology.
So let's talk about the actual technology a bit more specifically for a moment. So obviously the next generation sequencing technology has come a long way since you started using it 10 years ago. There's a lot more options available. There's been a lot of advances. So now looking at trying to use this more and more clinically, what are some of the main challenges in terms of the instrumentation and the methodologies that that might need to be addressed to make it more appealing or more usable in a clinical sense? What are clinical researchers and doctors looking for when they're looking to bring this technology into their methods?
I can tell you what my ideal world looks like, because especially in clinical practice, research folks, when I'm wearing my research hat, I pride myself on doing techniques that no one in the world can do other than in my lab, right? In clinical work, that doesn't work. Your work needs to be reproducible, because the patient you are treating today is going to be treated tomorrow in Egypt or in China or in the USA. So that cannot be an art. It really needs to be more of a science. We are subject to high level of scrutiny by accrediting agency. They want to see reproducibility. So I would say that the ideal next generation sequencing, or the next generation sequencing, would be very robust, very reproducible, and as less expertise intensive as humanly possible. The standard in clinical testing is that it needs to be performed by the minimally competent, well-trained technologists, not to be performed by the world expert, because it needs to be implemented widely so that it's accessible to all patients in many labs, not only limited to top-tier labs. I can tell you, when we started next generation sequencing, it was like, it really was complicated. But now, more and more, and the level of technology that we require to be able to handle the test was really very, very high, which makes them a rare breed. Where you're going to get such a highly specialized, probably these are, doing their PhD, and they're not going to stay long in this clinical lab. But now, minimally competent, well-trained technologists can actually perform next-generation sequencing with high level of reliability. So you need a very robust technology. The next thing is to be affordable. It cannot be ridiculously expensive, because then it is not accessible to all your patients. Then you need to justify why we are doing this expensive test for this patient versus having it, widely accessible for everyone. And the last thing I would say is to be fast, because now this is not a retrospective study. We are doing it, and when we get around to complete typing and we analyze the results, we submit the manuscript to Nature. No, there are physicians waiting on the other end of the phone for the results to know, however, treat rejection, think of something else like infection, or what is it that they need to do, and they need this information as quickly as humanly possible. So I would say that these three criteria are essential in wide adoption of the technology.
Yeah, that makes sense. And I think, it does seem like that's the way the industry is going. That's where the technology is moving. So hopefully that will have more of an impact in the coming years. Looking forward for your work then, are you going to be focusing more on that aspect, on trying to bring this technology closer and closer to regular clinical use, or are you going to be looking more on like, okay, what's the next new thing? What else can we do that we haven't thought of yet? What's the kind of the blue sky research?
Well, I think this technology still has a lot to offer. When I first started 10 years ago, we were only doing genotyping, HLA typing, and the other typing of other loci. Then we worked closely with the companies. At the time, there were not reagents on the market to do chimerism analysis for engraftment monitoring in post-transplant. And actually, I think our lab really helped to bring these kits to the market. And that really did a lot of improvement. One, it improved the level of sensitivity from 5% to 0.1%, which is 50-fold increase in sensitivity. Can you imagine when you increase? Imagine if your car that is parked in your driveway, you drive next morning and it is 50 times faster. Can you imagine what you do with that? So that's what we have. And now, which really allowed us to use it for other applications other than just engraftment monitoring. Now we are using it for early detection of relapse or minimal residual disease. Now with next generation sequencing, now the single molecule sequencing, which is referred to as third generation sequencing, allows the next generation sequencing that initially was 3-day workflow. Now it's about 20 hours workflow to get high resolution typing results in 6 hours. Can you imagine? If someone told me 10 years ago that we'll be able to get next generation sequencing or a derivative of with high resolution typing in 6 hours, I would have been very skeptical. But that's what we are validating now, which really allows us to do high resolution typing on urgent cases of deceased donor where organs needs to be allocated within short period of time because of cold ischemia time, that the organs needs to be transplanted fairly quickly. So I think this technology still has a lot to offer, and we will be using even the same tests in newer clinical applications, or even introducing new tests using the same technology.
Fantastic. All right, we'll wrap up there. Thank you very much for joining us. Thanks for sharing your expertise with us. That was a brilliant discussion.
Thank you so much. It's a pleasure.